That would be great.
Why?
So when I sent this to Don, it was entitled From Doing Things Right to Doing the Right Things Right, Evidence-Informed Decision Making. If I was going to give this talk now, again, I would retitle it and call it Preventing the Unintended Harms of Our Good Intentions. All right? So this is Alan and I. This is Alan's kind of summary from yesterday, just so that it makes a little sense why I'm following him, why we're together. So this is a little bit kind of what he came to, and I hope we got some of this, was family physicians will need to develop trust relationships in the future in some different ways. It's not going to be necessarily the same. Family physicians will need to manage chronic care as well or better than other providers. I think that's a key issue for that hedgehog concept for us. In order to do this, we're going to need to make decisions better. And that's really why I'm here to talk about that. We got a lot of low-lying fruit that we can do a whole lot better than we're doing. And I'm going to throw it out there that if we don't lead this, somebody else is going to lead it, and we should be leading this. This is our day. It's like from great if things come from great opportunities, today is our day. But if we don't take it, it's not going to be there for very long. All right, so this equation, values quality over cost, runs a lot of this. Now the interesting thing is Alan and I were the first people to publish this in the Journal of Family Practice in about 2000 and applied it to medicine. We went with some work with David Eddy where we talked about overuse and misuse and underuse, and we said that actually applies to this equation. Paul Fisher many years ago said any great idea that family medicine has, internal medicine will steal it. I was talking to the dean of UVA before I left recently, and I told him about this a little bit, and he said, oh, you must have just been out in Utah because the dean of the University of Utah presented that equation. And I said, actually, I published that in 2000. And he looked at me like I was a total idiot. There's no way that this family doctor sitting in front of me could have been the person who published that. But we did. So anyway, values, quality over cost. Three things affect that equation, and we should be talking about those three things every day. Underuse, misuse, and most importantly, overuse. And I'll come back to this over and over again. So this is an incredibly important slide, this one and the next one. Warren talked a little bit about this, some of the other guys did. Nobody quite showed it the same way, but this line right here is the inflation rate in the United States since 1945. It's about 3% per year. We know that healthcare traditionally has gone an average of about 3% higher than the inflation rate. Whatever it is in any given year, healthcare is about 3% higher. So when you put that on here, it looks like that. Now the problem is we're right about here, and it's going to get a lot worse. And we talked about this is a GDP of about 30%. The biggest problem here is this is just the cost of that 10%. Remember we talked about what's the cost of everybody's health care? What we do is the 10% part. This is the cost of that 10% part. The worse this gets, the worse the social determinants of health are going to get. Every wasted dollar that we do as family physicians or everybody else does on overuse is a dollar that makes food cost more, clothing cost more, shelter cost more. When we do overuse, we're harming our patients, but we don't see that harm. That's why it's the unintended harm of our good intentions. But it's incredible harm, and we've got to look at it, we've got to address it. All right, just give you some examples. I was asking some of the folks here how large your deductibles are. So I'm at Atrium Health right now in Charlotte, North Carolina. It's the largest healthcare system in the country, except for the VA. They have 200,000 employees, over 230 hospitals, 3 states, largest healthcare system in the country. I pay about $300 out of my pre-tax money for my health care every month. It covers me and my 3 kids that are in college. My deductible is $11,000. That means I got to pay the first $11,000 before insurance pays anything, except for preventative care. All right? Now, I hear the nurses that I work say, you know, we don't have insurance at all, because everybody there has the same deductible, minimum of $5,000. And it's huge. One of my colleagues works in the spine center, and she talks about patients. She told me one the other day that it was a young woman, 29 years old, that came in with some symptoms that made her worry that she probably had a spinal tumor growing. And she said, we need to get an MRI. And the person said, that's going to cost me like $3,000, because she hadn't met her $5,000 yet. She said, I want to wait a couple months and see if it goes away. we see this all the time, where people are possibly getting harmed because they can't afford that, even that $5,000 deductible. And it's going to get bigger. If it's not $5,000 where you are, believe me, if you go back to that slide, it's going to get there. It's going to be a minimum of $5,000 if it's not going to be more. So what are we doing? We're doing huge deductibles, trying to control costs. We're also doing all this stuff that we're talking about, clinical decision support, QI management, tons of this stuff. Question is it really making any difference? Is all this clinical decision support, all the protocol management, everything we're doing, is it really making a difference? Well, one of the problems is we're measuring processes, we're not necessarily measuring outcomes. We can measure hemoglobin A1Cs, but we may not necessarily, just turn off.
Yeah, you need to hit it again. It's
It
time.
did turn off.
Is it on?
How's that?
Yeah.
So we can measure hemoglobin A1Cs. We don't necessarily measure whether the interventions make people live longer or live better. I want you to remember this phrase. We can do things right, and that's what QI is all about, making sure we're doing things right. But it doesn't necessarily mean we're doing the right things right. And a lot of what we're doing that we think are things right is actually overuse and causing harm. But it's an unintended harm, and we think it's a good intention. I'm going to give you some examples at the end to help us start to think about this. This was an editorial that was in New England Journal of Medicine last August. Did I just go with that again? CMS has 86 QI indicators for primary care. They looked at the evidence supporting those 86, and only 37% were based on good evidence. 35% of the things that we're held to do were actually the evidence says are harmful things. That's today. I just died again.
Must be the battery.
Yeah, probably better.
I can hear you no matter what.
All right, I'm going to pass this off. It's getting annoying. So how do they get those things? They said basically they pull together a bunch of experts. They bring them together for a weekend and they just put a bunch of stuff on the wall. And then at the end they go through them and they vote on them. And if 6 out of 10 experts say this should be a QI indicator, it gets included. That's the process for those things that we are mandated to do. Remember I told you that the evidence is the worst person to evaluate the evidence is an expert in the field. Got to be bidextrous here. All right, so the other problem is that it reduces underuse. All right, remember value is quality divided by cost. If we reduce underuse, there's things that we do that we're not doing. It improves quality, but it also raises costs. And we don't gain much value. But overuse and misuse, when we stop that stuff, we improve quality and reduce costs at the same time. That's where the major value is. So doing the right things right. Right now, you know, Alan and I travel all over the world. You were talking yesterday about reimbursement models for family medicine. In Saudi Arabia, they basically have a system that pays for everybody's health care. And all the specialists are on a salary. And they pick how many specialists they need based on actuarial data. And the specialists make the same amount of money whether they see anybody or not. The family physicians are basically paid according to the referral rates. The more referrals they make, the less their value is. The smarter they are, the better decisions they make, the more they're paid, the more valuable they are. So that's an interesting model, just something to think about. But anyway, this is from when we were in the UK and they asked the question. Let me get this one around. You got me? So we were in, Alan and I have gone to the UK a number of times to help them with their clinical decision support because they're clinical decision making, not support. Because their big problem there, they're trying to pay for health care, but it's so expensive they can't pay for it. And they say basically they're what's killing them. They've cut out everything. But what's killing them is chronic disease management. So they asked us to help them when we were there with a bunch of experts from all over the world and they came out with this thing. We have to think about RIDE whenever we're talking about improving clinical decision making. Do we have the clinician in the right system at the right time? System 1, System 2. System 2 takes more time, but it's what family docs really should be getting value for is System 2. We need to make sure we're implementing at that decision making the best information that exists at that point in time. Evidence-informed decision making. make sure we dampen down biases, and make sure we create external safety nets, social determinants of health. Can people afford their medicine? Can they get there? Whatever. So Alan and I, this is our big thing. You all know this. We've spent the last 30 years working with information mastery. How do we make sure that we've got the best information there? So, real quick memory trip tour of information mastery. Our first paper came out in 1994, feeling good about not knowing everything. We introduced the concept of poems. So basically, first let's decide just for a moment that, for sake of argument, that we all agree that better information most likely results in better outcomes. Always use the example of the two cavemen. They're going out hunting. One knows where the tiger's hiding in the bush, the other one doesn't. Chances are the guy with the better information is more likely to return alive. So better information usually means better outcomes. Now, where are we getting our information from now? Mainly two sources. Warren mentioned this yesterday. CME, lecture-based CME, and journals. Problem with lecture-based CME, actually, Warren, there's 126 randomized controlled trials that show that there's no improved patient outcomes when we sit and listen to a lecture. Doesn't mean there isn't, but there's no evidence that there is. Absence of proof is not proof of absence, but 126 times you look for something that's not there. Chances are, if it is there, it's minuscule. All right? Journals, problem with reading journals, I do a lot of this talks in front of experts, and I say, raise your hand if you read Lancet every week. Raise your hand if you read BMJ every week. Raise your hand if you read JAMA every week. New England Journal of Medicine every week. All your specialty journals. Raise your hand if you read the clinical epidemiology articles and how to read the articles. Nobody has their hand up, right? Nobody can possibly look at all the journals and read the articles on how to read the articles. Make sure you know what an appropriate composite outcome is. Intention to treat, allocation, concealment, judicial assessor blinding. All those things you have to do to determine whether you can trust the validity of an article. And look through all those journals. How can you possibly do that? Nobody can do that by themselves, but there are systems that can do that. Now, information mastery. Usefulness equals relevance times validity divided by work. If information's relevant to us but it's not valid, it's useless. 0 times anything is 0. If information is valid but it's not relevant, it's useless. If the information takes both relevant and valid, but it takes longer than about 45 seconds to get it at the point of care, it's useless. It takes too long. So we need systems that give us every single day, at that exact moment, the most relevant and valid information to make that decision on that patient and make sure it's available in 30 or 40 seconds or less. We have those systems. We've had them for years, and very few of us are using them. It's not up to date, I'm sorry to tell you, and it's not Google. All right? But we need to use this stuff. So we got to have a system that makes us aware of new information. One of the things I've been encouraging Warren, Allen, I've been doing this, and members of the board, is we have to check for maintenance of certification that clinicians who practice have a system that makes sure that if there's something in Lancet that's incredibly important, it's going to change the lives of their patients, and it was a month ago, they need to show that they've already found out about it. The average amount of time is at least 2 years. But we can do better. We have systems to do better, but we're not using them. And I'm going to show you the data on what those systems can do for us. We also have a tool to find the information when we need it, a hunting tool. And these two systems have to work together. All right, so poems. We all know poems. What are poems? So we look at 140 journals every month. Thousands of articles. There's 7 of us. And we ask the question of every single article, these 3 things. Did they study an outcome that patients would care about? They only care about living longer or better. They don't care about blood sugars and cholesterols. Do I live longer or better as a result of this intervention? Is it common to our specialty, family medicine? Most importantly, if it's valid, and we always say we never know validity with probably 100% certainty, but if we know validity with a high probability of correctness, would it require me to change my practice? Now, what does that mean? Well, I look at JAMA. This was an article on the last day of December 2017 in JAMA. It was it was a systematic review of every randomized trial in the world that people could find, over 51,000 patients, and it asked the question, is there any benefit to vitamin D preventing fractures? And it turns out, and get ready for this, you're going to all do the moral reflex, it turns out in women average women, not women with osteoporosis, but just average women, starting at the age of 50 until they're 65, if you give them vitamin D as compared to placebo, they are statistically significantly more likely to have a hip fracture. It is harmful to give vitamin D to the average woman at age 50. When I tell the endocrinologists, they do the moral reflex. Right? Why is that? And Jocelyn, here's the answer to your question. Because we are all imprinted. We have been imprinted right here to favor what ought to work. Our medical training teaches us what ought to work actually takes precedent over what does work. We all say we do evidence-based medicine. We do, but only if it fits with our paradigm of pathophysiologic thinking. And this is where our overuse happens. We have to train students and residents to think differently. We have to use a probability-based decision-making approach, and it has to be used with the hierarchy of evidence. We can't just depend on what here. Here it is. Konrad Lorenz. You remember this from your first year psychology class where the little ducks followed him around because they were imprinted to him? These are the little health students. This is us. And that's pathophysiologic reasoning, and we're imprinted. And it is harming us to do that. It's harming our patients. So this is a study that Rowland Brandon and his group did at McGill. So for the last 12 years, the Canadian Medical Association pays for the poems to go to every single doctor in Canada. They all get the poems every day. And this is data that Rowland and his colleagues at the McGill got. This was published in the Journal of the American Board of Family Medicine in 2015. They looked at over 500,000 responses to 530 poems. And the number one most important response that the clinicians said they were going to do with this new information, 59% of the time, was to stop doing something that they were either doing or getting ready to do that was going to be overuse. That was the most important outcome of looking at those poems. Right? When we studied, when he did this in 2015, just in that 1 year alone, there were 29 poems that identified interventions that were not even yet on the Choosing Wisely list. Things that doing to patients caused lower quality and higher costs. All right? Drove that curve up faster. 29 things that we do in family medicine. One of them, Grant, a long time ago, Grant spent an incredible amount of effort at the University of Michigan to get docs to quit ordering random or vitamin D screening on everybody. This one was like 8 or 10 years ago not to do this. Right? We're still trying to get folks at Atrium to stop doing this. They spent $3.5 million last year at Atrium Health on population screening for vitamin D levels. $3.5 million in 1 year. Right? And you can't get docs to stop doing it because no matter how many studies there are, you can go look at the poems. There are probably 80 poems that show that vitamin D in a randomized controlled trial doesn't do anything. You can also show 80 studies that vitamin D low levels are associated with every disease you can think of. All right?
How many poems of it, you say they're delivering these every day in Canada?
It's one a day.
It's one a day?
Yeah. And so what happens is that, yes, low vitamin D levels are associated with about every disease. But how do you get low vitamin D level? You sit in front of TV. You eat chips. You don't do dairy products. You don't go outside. You don't exercise. Of course it's associated with every disease. But every randomized trial that says if you raise the vitamin D level, does it fix the disease? Every single time it's said no. Except maybe with asthma, and even that's not so good. All right, so we now do, in the American Family Physician, we've done every year now for the last 5 years, the top 20 avoid overuse poems of the year. Right? How many people read those? How many do you think that the docs out in practice look at those? No. And we get them in a big bundle. Nobody's going to remember them in a big bundle like that either. Right? But you get them one at a time, you talk about them, it can actually make a difference. So, what's this all coming to? So, you know, obviously this is Alan's and my thing and many other of us. We've all got to do a better job of evidence-informed decision-making. What ought to work, or excuse me, what does work should take precedent over what ought to work. Right? When I was a resident, we gave intravenous lidocaine to everybody that came into the coronary care unit having multiple PVCs. All right? I killed every 10th person I did that to. If I'd given them placebo, they would have left the hospital. They figured out if we put a memorial on the Washington Mall of all the names of all Americans who died with intravenous lidocaine compared to if they got placebo, it would be 4 times the size of the Vietnam War memorial that's there right now. This overuse stuff that we do in the name of pathophysiology is incredibly harmful. All right? The question is just how much of the stuff we're doing right now is there. So I worked very hard at Atrium in getting them to realize their enemy is not variability. Their enemy is overuse. It's not about reducing variability, it's about reducing overuse. So we have to do this both reactively and proactively. Grant Greenberg has set us up with David Price, who is a family physician, but he's the executive vice president, whatever, in the American Board of Medical Specialties. And they're incredibly interested in our online course and doing a performance improvement module that will show that clinicians who learn this stuff and use these tools will identify both overuse in their practice currently, and even more importantly, show that they will avoid overuse in the future. Not necessarily just the QI we're doing now about making sure that we're doing things right, but they can demonstrate that they are doing the right things right both now and in the future by doing this. So this would be the first module ever like this that we're working on to do this. And David Price told us, he said, I think this may very likely be the only thing that he feels strongly that people are going to feel is incredibly valuable in the maintenance certification process, that they can learn to do this. All right, so we have to create our culture. This is what I talk about at Atrium. It's all about the culture. We all have to have a no-fault approach to helping each other with overuse. It's all about overuse. How do we go after that stuff? I was telling some people at lunch today, or breakfast this morning, there's a guy who's the head of Atrium Health. This guy he's a neurologist. He makes like $3 million a year. People treat him almost like he's God. But he basically, when I first came there, he kind of sneered at me, and he told me, this is all about variability, and I, as nicely as I could, tried to redirect him. People tell me now, he hasn't admitted this to me, but he walks around now, everywhere he goes, he gives a talk, and he says, the #1 nosocomial intervention in medicine today is overuse. If we're going to do something about healthcare, we've got to do something about overuse. Doing the right things right. So in the unintended harms of our good intentions. Now what I'd like to do is just give you a couple cases to give you an example of stuff that we do ourselves every day that we think is good, but it's actually causing harm. You ready for this? There's going to be a little bit of moral reflexes here. Joe, get ready. All right, here's the case. A routine physical exam in a middle-aged woman includes fasting blood glucose, which is elevated. A follow-up hemoglobin A1C is 6.3. Patient's given a diagnosis of pre-diabetes, referred for diet counseling, and started on metformin. Imagine doing that? Yeah. All right, so here's the questions I want you to think about for a few minutes. What is the pathophysiologic reasoning that prompts us to make those decisions? How might that lead to overdiagnosis, overtreatment, or harm? And how would probability-based thinking, reducing overdiagnosis, overtreatment, actually make a difference there? So just think about it for a couple minutes. Actually, for 30 seconds. Alan.
So there was somebody, I think it's at Mayo, Montori, endocrinologist,
Minimally disruptive.
once presented at Masquerade and said, how stupid is it to start somebody on metformin for prediabetes to prevent them from needing metformin as a diabetic?
All right, so let's talk about it. What's the pathophysiologic reasoning that prompts us to do this decision? All right, it's basically recognizing and addressing prediabetes will prevent the development of diabetes, reduce mortality and morbidity. The lower we can get somebody's blood sugar, the better things should be, so we do that, right? Now remember what I'm talking about is screening, right? It doesn't mean, Alan said this very nicely a couple of years ago, screening means finding something at an asymptomatic time as opposed to treating the same thing when it has symptoms, right? Doesn't mean treatment doesn't make a difference, it just means when you start the treatment. and what harm it might be by starting the treatment at a different time. That's what we have to think about. All right, so how might the pathophysiology lead us to overdiagnosis, overtreatment, or harm? This is the one where you get a flow the moral reflex, but this is the Cambridge study. It's now the largest study in the world, the only one that's looking at randomized trial that says we're going to screen these people for diabetes, and these people we're just going to wait and treat them when they have symptoms. They are now 10 years into this trial, and neither lifestyle intervention nor metformin, nor both together, has decreased cardiovascular mortality or morbidity. It delays the diagnosis of diabetes, but it does not make people live any longer or any better to start it pre-symptomatically as opposed to when they just have symptoms. We're 10 years into that study now. Right? How might that cause harm? And this is the issue of disease labeling. All right? And it causes incredible harm. And it also, just tell you in the article in Science this week, it's a multi-billion-dollar industry on prediabetes. They're making tons of money on that diagnosis and the worry that it causes. But if you give somebody the diagnosis of hypertension, this was a famous article in New England Journal of Medicine, the next year, even though you treated them and you told them they were fine, they missed on average 5 more days of work because of stress. The United Kingdom found out there was no point. You know how we do those wellness screens? You guys do those? Every year you got to know your numbers. Everybody's got to get the sugar, their cholesterol checked. The UK, they did one population, they got it, and one population, they never tested it, and they're 20 years out now. Well, actually, they stopped the study because the only difference was the group where they were testing it, they had more lost work and more sick days and higher anxiety. There was no reduction in cardiovascular mortality with wellness screens. It just wasted money and caused harm. So again, prediabetes, Al and I were at this conference in Copenhagen in August. It was the 6th International Conference on Preventing and Eliminating Overdiagnosis. This is a world issue that's just barely come to the United States. There are 400 countries there. 400 people from 30 countries there, very few from the U.S. In fact, they kind of snarl at the U.S. because they think we're never going to get there. It's the old quote from Winston Churchill, you can count on the Americans to do the right thing, but they got to try everything else first. So they still see us that way. But basically, a lot of people talked about the whole prediabetes thing and the harm that it causes. There was a guy from Canada that said, here's one of our biggest problems in Canada. People like to go to the United States in the wintertime because it gets pretty cold up here. And when they go to the United States, for more than 6 weeks, their insurance stops covering them. Their Canadian insurance stops, so they have to buy supplemental insurance. And they said if it says pre-diabetes on their problem list, they can't get the insurance. So it basically makes them so they can't go on vacation if they have that diagnosis on their problem list. So it's a real big thing for them, and it also makes their insurance cost more. So now, one more case. This is what we call the masquerade. So things that we think are underuse may actually be overuse. How about the diabetic foot exam? Oh no. Is he going after that one? All right. So whenever you look at a diagnostic test, there's 4 things you got to ask about that test. And we always get stuck on the first one. 4 things. How accurate is the test? I.e., how sensitive and specific is the test? Number 2, if I order the test, will it change diagnosis? Number 3, if I order the test, will it change treatment? Most importantly, number 4, if I order the test, will it change outcomes? Will it improve patient-oriented outcomes? Not disease-oriented outcomes, patient-oriented outcomes. Because we spend a lot of money on tests. We are the kings and queens of screening in primary care. So, how accurate and sensitive, specificity, negative, predictive value is that Semmelweis, whatever that test is? The Pokin thing? How good do you think it is? It's not too bad. All right, wait a minute. Well, these are the 4 things, sorry. Ipswich touch test, it's called. Sensitivity, 78%, specificity, 96%, positive likelihood, 23, negative likelihood ratio, 0.02. Not bad, right? So what happens if somebody can't feel that thing? We give them a diagnosis, right? They got diabetic neuropathy. I always get neuropathy and nephropathy. Got to get the word right. Diabetic neuropathy goes on their chart. right? What do we do differently?
Get offended.
They're not, now remember, they're asymptomatic. They're not having pain. We just poked them to see if they have it. They're in the pre-symptomatic phase. What do we do differently? We have them look at their feet every day, right? What else do we do?
We reinforce their diabetes.
We reinforce their risk factor management. What else do we do?
We make sure we code it appropriately for HCC.
Right, we code it appropriately.
That's what I was going to mention. You get higher reimbursement for your Medicare Advantage.
All right, hold that thought. Remember, 35% of those things were wrong. All right, what else do we do?
On QI because we're required yearly.
Exactly, and who can lead the way to change this? What else do we do?
We stress out the patient, which then their sugars go up because they're stressed.
Is anybody going to do the special shoes thing yet?
Yes.
Yeah, okay, good. All right, so hold those thoughts. All right, so turns out that there's no evidence that the risk factor management improves by getting that diagnosis. There are so many trials, you would be amazed how many poems there are of things that we keep, they say that stupidity is doing the same thing over and over again, expecting a different result. We keep thinking that because we tell people that they have something that's going to change their behavior, and we keep looking and looking and looking. Carotid intimal lining, coronary calcium scores, all this stuff, we think, oh, now they're going to really start taking their cholesterol medicine. Sorry, it doesn't work. People don't change their behavior just because we tell them they're more at risk. It sounds great, but they don't. Multiple studies showed no difference. Special shoes, there's a Cochrane review. Special shoes help ulcers to heal, but they don't work any better than anything else with preventing ulcers. There's a Cochrane review on daily inspection. It doesn't make a difference. It doesn't change outcomes. Every intervention that we can do, once we put that diagnosis on there, does not change outcomes, but it costs money. All right, and it's causing harm. But it's a good intention, but we have to start to recognize that. So it's a time waster, labeling, anxiety, all that stuff that you talked about. All right, so Al and I, our course, we're working on this. It actually should be available Monday as on the MOC thing. One of the, it's already been approved, it's got prescribed credits. It's an 8-hour course. You get certification in evidence-informed decision-making. It's going to also be with the American Board of Medical Specialties, and we're working with them to make it a performance improvement module. Now it'll just be a self-assessment module worth 10 MOC credits, 8 prescribed credits, but it's essentially learning to think this way. Training people, there are 7 medical schools in the country now that use our course to train medical students from the very beginning that it's not about pathophysiology, it's about probability-based thinking using a hierarchy of evidence. And they're going to be re-imprinted differently than all of us. The hard thing's going to be for our generation to change the education because we ourselves are going to have to teach something that we don't even know. So it's going to take some work for us to do this. The biggest mistake medicine has made in all the years have been all the times we had the paradigm wrong. James Lynn figured out that if you give sailors citrus fruit, they don't get scurvy. It took 200 years before medicine paid attention to that, because it didn't make sense that citrus fruit did anything, because disease came from vapors in the air. Semmelweis said you wash hands and it made puerperal fever go down by like 20%, and nobody paid attention because bacteria hadn't been invented yet. The Cochrane collaboration, that logo, is a memorial to the millions of babies that were born with hyaline membrane disease and bronchopulmonary dysplasia because we ignored for at least 15 years that steroids prevented hyaline membrane disease, and it's a memorial that will never do that again. But our paradigm of thought has historically been incredibly harmful, and our current paradigm of pathophysiologic thinking is harmful. It's not wrong, it's on the spectrum, but it's wrong to go with it first when there's better evidence. I know you're going to have all kinds of stuff and you're going to think, but I'm open for questions and we can talk about it. But hopefully you'll think about this. Bloodletting, yeah. You ever watch that thing with from Saturday Night Live? Yeah.
What's the course called?
It's called Evidence-Informed Decision Making. I think it'll be under Information Mastery, but I was hoping I could tell you today, but it should be there Monday or Tuesday.
David, What kind of reception do you get depending on primary care or specialty audience?
You know, Mitch, we get very little reception. I mean, Alan and I have spent our entire careers going to foreign countries. I'm on the faculty at Hong Kong University because America has not wanted to hear. Alan, what are those 8 stages of change? What are they called again? I'm sorry. Eight stages of change. What's that guy's- Okay, so number 1 is there has to be an urgent need for change. We haven't got it yet. Cost of health care will be that urgent care, that urgent need, but I'm afraid it'll crash before we finally pay attention to this stuff. But family medicine has a chance to lead the way. We have the best tools already. We can do this. We can take the chance to do it, or we can just let it go, let somebody else do it. Follow instead of lead, but this is our chance.
David, first of all, you and Alan are 2 of my heroes, and I think the work that you're doing is incredibly important. But I think that your whole slant is not quite where I think it could be to have greater influence. For example, every example you just gave about scurvy and puerperal fever, and we could do William Banting and the discovery of insulin and treated 6 kids and it went to the world. That was pathophysiology. I don't think bashing pathophysiology is what you really want to do, because medicine advances through better understanding of human biology and pathophysiology and then empiric evidence. And then you guys, the RCTs are a mop-up operation. Let's get rid of, our disordered thinking, or we were off base. And, so you gotta, your usefulness slide was wonderful, because usefulness and kind of validity. Right now we have this enormous disconnect on vitamin D. Vitamin D, humans biologically are designed to become vitamin D deficient. Our skin doesn't make vitamin D from the sun when it gets old. That evidence has been around since the 1960s. We don't eat organ meats anymore, the #1 source of vitamin D. Dairy supplementation is not a good way to get vitamin D. Evolution didn't care how long we lived, they only wanted us to reproduce. So biologically, we are designed to become vitamin D deficient. The World Health Organization calls it a disaster with 1 billion people on Earth who are vitamin D deficient. It runs thousands of chemistry reactions. Every cell wall depends on vitamin D. There was a study just came out this week that neurogenesis requires a healthy vitamin D level, and we get brain atrophy. Now, the problem is that nobody's done the study yet that said screening for vitamin D has definite value, and nobody's figured out the way to deal with vitamin D deficiency in a way. And the trouble with RCTs, it's single variable. Does vitamin D prevent fractures? That's not the answer. The question is how important vitamin D to a healthy biology of a human being. And the number of variables is enormous. And all these single variable studies that come out negative now has made vitamin D the darling of EBMers bashing overuse. And yet the pathophysiology and what we know about the importance of vitamin D deficiency, we still have a problem yet to solve. But I think we need to embrace pathophysiology. We need to embrace better understanding of human biology and move forward carefully, and then clean up our mistakes.
Just a couple things. Every time I give this talk, somebody usually starts by saying that I've just bashed pathophysiologic thinking. And I hope you saw that I did not. That was part of the spectrum. I always ask people, who's ever seen vitamin D building a wall? Anybody ever seen it? No. We all believe it does. We were all taught that, but it's faith, right? It's faith as much as anything else. We believe it because we were taught it, but we've never seen it. Right? 50,000 women say, give me vitamin D instead of a placebo, and I'm more likely to have a fracture. Okay? I don't know which you want to believe more, but we're not saying that pathophysiology is not important. But remember, I use pathophysiology because it was that RNT phenomenon that went away when we gave lidocaine, and we killed every 10th person I used pathophysiology on. And it was only when we did the RCT that we realized, actually what we realized was we had the pathophysiology wrong. It was not the RNT, it was the negative inotrope that the lidocaine was making worse. So the two have to go together. We need them both. Not one can completely replace the other, but one has a higher probability of the truth than the other.
So with the vitamin D, I think the challenge is having people be comfortable not having information and being able to guide patients without information. It's not, I'm not going to get into whether vitamin D and physiology. What the issue is that everyone's vitamin D deficient, like you said. So why do we need to test? And why do we need the number? Why can't we just tell people, yeah, you need vitamin D? That's the crux of the vitamin D argument. And I think so the last talk and this talk, the power is that we talk about, okay, we need to do the clinical aspect of medicine, and we also have to be stewards of resources. And I think that we have a powerful potential to not do things and be stewards of resources and do it in a way that makes sense for the patients if we coalesce things in the right way. So it's a fascinating topic.
David, I'm much more on David's side of this, and as David knows, has been working in the 90s around these things. And two comments is that, this goes back to the Greeks. There's always been a tension between empiricism and rationalism. What we're now seeing is the return of empiricism to the discussion, and that's appropriate, and it's leading the way to a kind of post-Flexnerian kind of age. So, it's going to go back and forth. The other comment I'd make, just by sort of where the boards are, I've looked at the details of what all 24 boards are looking at. And the big thing that's missing, other than communication, which I mentioned, is any attention whatsoever to cost. And I find that a blindness that is striking. The only board that is dealing with this will be surprising to you. It's urology. And what urology does, if you go to the website, their focus on professionalism is around the ethics of urology, and particularly the doing of procedures for which there's no evidence. And the way they operationalize their definition of professionalism is they have urologists download the CPT code that they're doing. And if you're doing a CPT code, they've identified ones in which there's no evidence. If you're doing something that there's no evidence for, they will give you a warning, and if you don't change it, they will disbar you from urology. And none of the other boards are doing that. And I'm going to, and certainly my world and your world, everybody's talking about cost, from patients to legislators. The only board that's actually doing something in it with real teeth are the urologists. And how do we, so I'm real struck with this issue of the moral imperative to deal with cost. Everybody in this room is dealing with it, of course. That's what we're doing. But they're actually pulling board certification because of inappropriate use.
So everybody's worried if you reduce cost, you lose quality. And that's why overuse is the answer, because it reduces cost and actually improves quality.
So I found actually the prediabetes example really striking, and this, I'm going to speak a little bit to the cost too. I mean, the pathophys that I learned is you lose islet cells, which means that you lose endogenous insulin production, and then you're going to need insulin down the road. And so what I found interesting about your example is the outcome of interest was 10-year cardiovascular disease mortality, where I'm more interested in what's their cost 10 years down the road when insulin costs $400 a month, and what's their rates of needing insulin, which is a pro-inflammatory molecule. And it may be that none of that's relevant and the harm's far away, and I'm open to that being the ultimate answer. But one of the things I struggle with when I try to think this way is what's the right outcome to even be looking at? Because you presented a patient-oriented outcome, but is that the right patient-oriented outcome?
Yeah. So far, at least they didn't find any difference with that. Look at the Science article, because about a third of the people don't even progress anyway. And about a third of the people that we should be picking up were not. And there's really no difference in drug use or anything, except they are more metformin.
I'm struck with the same one, feeling like, I was struck with the same example. We have so much of it.
And is 10 years the right amount of time to look at? Because I wouldn't expect much in 10 years. It's
Yeah.
more than 30 years I'm worried about. And I don't know if we know that yet.
Yeah, but the question is what do we do if 10 years doesn't make a difference and maybe 30 years does, and we're spending way more on that than other things we could be doing? You know, this is what they have to do in the UK is figure out, we can't pay for everything, but we got to pay for what has the most value. And that's American, our way of thinking is if it has any value at all, we got to do it, and we got to get past that. I always, you know, the diabetic hand, the 5 things that matter, smoking, blood pressure, cholesterol, metformin, and I always say I don't have a pissing contest whether the pinky exists or not, but relative to the rest of the hand, it's minuscule, but we spend all our time over here. We don't do smoking cessation, we don't control blood pressure very well.